Hey everybody, this is your 5-minute warning. I know it's hard to start right at 5. People are getting off work. Make sure if you came in this way and you haven't already, we got some paperwork in the back if you need some more information. There's some flyers. There's also a little survey we're going to ask people to fill out. If you didn't hear from the beginning, this will be live streamed on the YouTube page for the library. So if you don't want to be on camera today, I would suggest you move to the very far edges. That's only going to film directly this way at the stage. So mostly it's just going to be the back of y'all's heads. But this is just so that we can make sure it's an accessible conversation and folks can listen who are online. So make sure if you don't want to be recorded, you're on the edge of the room. Also, same with the mic. If you do not want your voice to be recorded onto the YouTube recording, just don't ever pick up a mic. You can share with the written format, through the survey that we have. We have an online survey that we can share. You can also grab any of our organizers and ask them to maybe share a comment on your behalf. And we can do it that way. Yes, go ahead. So again, about 5 minutes. Make sure the bathrooms have a code on them right now, but we put the code right on the door. There's a men's restroom here and a family restroom here and a women's restroom in the back. And if you have any other needs, feel free to grab me in the next 5 minutes before we get started. Thanks. All right, everybody. I think we are at 5:05, so it's good to get started. I don't know why I pretend I could do a stationary mic stand. I am a chronic pacer, so here I am. Hey, everybody. My name is Hadley Morrow. I get to be facilitating our little listening session today. I use primarily they, them pronouns. I am a freelance facilitator. That means I get to hang out with a lot of different folks who are struggling with trying to figure out how to make cool ideas happen. And try to help create conversations and frameworks that make it easier for us to get together as humans and come up with really cool solutions for hard problems. it's a pretty cool job, I think. And I'm super grateful that I get to be here talking to you all about something that's really important happening in our community right now, which is a conversation about the future of our public health services as it relates to the opioid treatment program. I gave this spiel already, but I gotta do it again. If you're here in person, in the back there are some flyers that have some more information about what we're talking about today. There's also a little survey. Throughout this session, I'm gonna be referring to that survey. Also in the back are like flyers. We're gonna do a couple more town halls. This is our big in-person town hall, but we have 2 more Zoom town halls we're gonna do. There's also an online survey going around, so like other spaces for people to give input on this, super important. Make sure you feel free to talk to anybody at the tables back there if you have any questions about those things. To get us started, I'm gonna talk a little bit about, what am I being hinted at? You can tell me. Oh, thank you. Yes, I will one more time for if you don't want to be on camera. The camera is like stage center, like it is giving me straight, like right on vibes right now, down to this row here. If you do not want to be on camera today, make sure you hang out at the edges of the room, and that's totally okay, totally understand that. I want to be clear that this process is as anonymous as possible, which means that everything that I write down from today, everything we get from the comments, everything that you write on your sheets, those we're going to scrub out of any information at all that could possibly lead to someone guessing who you maybe are. But that doesn't change the fact that you are in a physical room right now, which is being recorded, and there are health district staff here. So we just got a name that I want you all to be aware of, like what level of anonymity you can grab onto today. If this is not a space where you feel like you can totally speak up or say exactly what you want to say, then I really encourage you to check out that survey link and you can type out whatever you want to share. You can also grab me afterwards or grab like any of the number of volunteers afterwards. We can find up a time to talk to you separately and set up an interview or figure out a way to talk, because we really want to get as many voices in this as possible. So as I said just a little bit, through this process, like this is a parallel process that's supporting the feasibility study that the health district is doing right now. I am not a health district staffer. That's why I get to hold this information with some anonymity here. And it's my commitment that all the questions and feedback from these sessions are going to be delivered directly to SRHT Administrator Dr. Alicia Thompson. It's easy because she's right here right now. But also, she's going to be getting my report. She's been attending these sessions, which has been a big help. And it's a chance for us to hear directly from the person who gets to make this recommendation. We're putting this all on with a little bit of help from my friends, who I got to give a shout out to. One, Experience Matters. They're here in the front row. Woo woo! Experience Matters is an awesome group of local leaders who are a coalition that represents a lot of different organizations that have been really standing up for the homeless community in Spokane. They kind of sprang out from a lot of the Camp Hope work, and they were really spearheaded some of the work to get the mayor to call a state of emergency for the fentanyl epidemic. So there have been some local leaders around some of the opioid crisis work that we've been talking about today. I also want to give a shout out to Range Media. They're kind of over there and around. Range has really been helping us to try to get this conversation into the digital sphere and get more people talking about this. Range shares my personal commitment in like really wanting to get more people chatting about big government decisions. Sometimes I think they can feel like really far away or complicated and hard to understand. So Range has been doing a great job of creating articles and explainers that go along with this process to help make it clear about this decision. And also through the process, they're going to continue to share articles and dig up more information. If you all have questions today that we don't have answers to, I know some journalists who can go do some digging. How convenient is that? Thank you, Range. They'll also be handling the live tweets today if you want to get on the Twitter. And of course, I got a shout out to the health district, who has been, again, being a really good peer and listening and being really wanting this process to go well and create some spaces for more community voice and conversation. And I'm leaning on a lot of trust right now that they're really listening to what y'all are saying. So why are we here? Today's goals. It's like, first, I got to be clear what we're doing. Like, why are we even talking about the opioid treatment services at SRHD right now? We're going to present the feasibility study, just give a little bit of background. Like, I want to give you just enough information that you can start to think and start to get curious, because I could talk for like 10 days about this. It's such a complex, complicated issue. But what we really want to do is just give enough information that you can all get sharing with us. I am kind of a nerdy data person, so part of my goal is to try to make this as standardized as possible while also allowing people just to have real conversations and like all of us just get to talk like normal human beings. That's why you have a little flyer in front of you, which does have, some 3 steps for how we're going to go through this conversation today. You'll get some chance to write if you're the kind of person who like would like some time to think and like write out your thoughts first before you share. That's great. But all of that I'm going to name, like we're going to be collecting that. So if you write something that you think is really great and you don't want to get rid of, I would take a picture of it and then give it to me. hot hack there. But mostly I just want to make sure like that's the way we're going to collect anonymous data from you all. And the other thing that we're going to do here is like if there's spaces where you're all confused about this process or need more clarity or really want to say, hey, health district, we absolutely need to know that you are thinking about these things or you are asking these questions or you're doing this kind of research in order for us to trust that the recommendation you make is really vetted through community voice. That's what we want to identify today because we still have this, about a month of a window of time where Alicia's working on her recommendation and is still sourcing all this information. Any questions about today's goal? Sweet. What is the big question? Why are we here? The big question is, would it be better or worse for the community if the opioid treatment program at Spokane Regional Health District was run by a private organization instead of a public health organization? Some of you might be insiders who are like, oh, I'm so ready to fire off an answer to that question. And some folks might be like, wow, there's a lot of big words in that question. So I'm going to break it down a little bit. The Spokane Regional, oh no! All right, hold on. If you're on the YouTube, you missed my dramatic, wait, we gotta like redo the connection. Hold on. Do I wait? We're gonna wait for 8 seconds. Does anyone have a 5-second joke? What do you call a cow with no legs? Ground beef. Ooh. All right, now I gotta come over here and redo my thing. 1 second. All right. I'm gonna do one of these magic ask a peer for help. Do I have a peer who could come up and get me reconnected to this while I just keep talking? Thank you, Amy. I'm gonna do my best to keep use of people's time. I can also read it to you. SJDP4. Oh. If anyone has another joke, this is another good time for community jokes. Fish with no eyes? Shh. Got it. Oh, I'm doing the Canva one. They're this one. Yeah. Oh, we're there. We're almost there. We did it. Team effort. Woo! Thank you. Gotta love technology. Not even like a clap for that. Come on, I just suffered a very long, awkward technical glitch. Help me, people. Thank you. I know we're tired. I know it's 5, but like, come on. I've been waiting all day for this. I'm here. I'm ready to have some fun. What are we talking about again? All right, so the history of Spokane Regional Health District's opioid treatment program. It really started in the 90s with the methadone clinic in response to the heroin epidemic that we saw in the late 80s and early 90s. As we've seen, the opioid epidemic has just continued to grow and change with the introduction of a lot of different kinds of opioids. We're talking also about oxycodone, hydrocodone, fentanyl, morphine, and this is, recognizes that the need for opioid treatment services has grown and changed a lot over the last 30 years. Now, the program itself at SRHD, when it started, there was no one else on the scene who was doing opioid treatment services because they were responding to a pretty new epidemic. And there were a lot of folks in the community offering this specific type of service, medication-assisted therapy or treatment. You'll sometimes hear me say MAT, MAT, when we talk about that. There's an acronym cheat sheet on one of your flyers, and feel free to just yell out, what the heck was that acronym? Because we do that a lot. But MAT, or SRHD, is using a combination of MAT and substance use counseling and mental health counseling to really help people address the withdrawals and the cravings that come with opioid use. Any quick questions about the opioid program? We'll have a chance for you to ask really good questions. This is my quick background. So what's the challenge? The methadone clinic, the opioid program, it's been going for 34 years now. It's been going strong. Why are we talking about this at all? The reality is this is a conversation that's kind of cycled for a long time within the health district, and this is the moment where they're kind of bringing it out into the community. So internally, folks at the health district have wondered, as the program has grown and changed, would it be better served as a public entity, as its own program, its own individual business, instead of being run under public health? Why is that? One, public health programs, so we call them local health jurisdictions in Washington, because sometimes it's just a county program, sometimes it's a multiple county program, like Spokane Regional Health District isn't just Spokane County. They actually serve a catchment area of multiple regions. So our jurisdictions, like SRHD, get a portion of the tax budget, like our state budget, to do a specific set of core programs that are called our core foundational public health supports. That's things like, disease prevention, like public health education. That's those great billboards about syphilis prevention that we're seeing out on the streets. Like, that's core foundational services. That doesn't mean that health districts can't do other things. Like, they can and they should react and respond to other health issues, right? What it does mean is the state is very specific about what the minimum requirements are. Like, these are the things that they absolutely have to do, or else they're not really in compliance as a health jurisdiction. And that these are the things that they have to use that the money that they get from the state taxes and our state budget for. Like, that's for these for core foundational services. So what that means is they're always kind of in a balancing game, right? Of like, they have to balance the responsibility to do these core foundational services with other opportunities and other really important programs that they might choose to take on. The opioid treatment program is actually an example of a program that's not considered a foundational service by our state law right now. That, is a conversation, like, separately. We could talk about where it lives in as far as like the state law. But right now, for today, it's not a requirement. So SRHD, when they want to have this program, they have to look at other ways to fund it and make sure that they're constantly balancing it with the responsibility to steward their role as like a taxpayer entity. So how have they done that? Fortunately, there's been a lot of opportunity for opioid treatment because the need is so great. They have been able to bill fee-for-service. That means they charge insurance, just like other businesses would do for healthcare services. They are able to access certain grants that are for specific programs, like helping pregnant people who are addicted to opioids in some specific areas where it's like really, some specific programming and public health issues. And for these 34 years that they've run the program, almost every year, they've broke even or like made money. It's been because there's been enough need and there's been enough services for this. Now, there's been like a handful of years, like literally a handful, early in the beginning, like back in the 90s when they were starting the program and like getting it going. And then in 2013, but then not again until 2023, where they ever had years where they were in the red and had to dip into some of that general fund or like the state taxpayer dollars in order to cover this program. Again, they're totally allowed to do that. Like, that is okay. It's just one of those moments where it's like, hey, we should check, right? Like, has the community explicitly said that they want us to do this opioid work? Because the state law doesn't explicitly say we need to do it. So like, let's just be really clear and take this opportunity to check in with community. Part of this conversation is happening because now the program is so huge. Why did it go into the budget red in 2023? What's happening right now in the opioid world that's a little bit different? We've been responding to a massive fentanyl epidemic. And the number of deaths due to overdose in Spokane County, according to UW data, from 2021 to 2023, nearly tripled. And almost 90% of those deaths were specifically because of fentanyl. The way that we respond to fentanyl needs to be slightly different to how we've responded to some of the other opioid drugs. And the treatment, so like specifically like what kind of medication assisted treatment and what sort of counseling is needed, looks different because it's a different drug. So that's required the health district to quickly respond and like they have to like figure like staff up the program, figure out how to grow, figure out how to change, figure out how to train folk, get new things in order to respond quickly, which can be harder for a government institution to do sometimes compared to a private business. Let's think about private businesses for a second. Private businesses, like, they're all about risk management, right? It's okay for you to take the risk and maybe like go in the red, lose some money for a while if you know that you're doing it because you're gonna earn that money back later. Maybe you're hiring a bunch of program staff right now because you're seeing the writing on the wall that there's a really big epidemic coming, and you're hoping that there's more funding later that's going to make this pan out. These are the kind of like risk management decisions businesses make, right? SRHD has to make those decisions too, but they have a slightly different nuance to it, which is as a public agency, they're under a lot more regulation and requirements for how they do that. They got to be way more transparent. When it comes to the budgeting, they do have to be thinking about that budget neutral a little bit more. So they can't be like, hey, we're going to just take a bunch of risks with taxpayer dollars and hope it pans out in the future. Often taxpayers don't like that. So they have to be stewarding that responsibility of how are we making sure we're not dipping into that fund. Now, again, that's not like this has been only a handful of years since this happened, but it's top of mind right now. Like one of the reasons we're having this conversation right now is because last year they did go into the red, largely because of the needs to respond to this fentanyl epidemic. So this is a moment where it's good to ask us all as community members and folks who are paying into this tax fund and needing our health district, hey, actually, yeah, what is the best way that this program could serve our community? Now, this is to say, like, no decision is being made right now. This is a plan to maybe plan, which is a funny thing with a feasibility study. Feasibility study is a fancy word for, like, let's go see if this is even possible. The health district's program is one of only 2 public health agencies in the state who's offering a direct service treatment program. So it is like semi-rare. Tacoma Pierce is the other big one. They've grown to like the biggest opioid treatment provider in our region, serving about 1,000 people, like 1,000 active clients, and a staff that's about 60 folks. So this is a big thing to figure out how to transition and figure out where a home for this could go. I want to be super, super, super clear. This is not a conversation about the health district cutting or getting rid of or terminating the opioid treatment program. I want to be super, super clear. This is a conversation about what is the best home for the program, and do you all as community believe the health district remains the best home, or is it worth exploring other options? This is a 3-phase feasibility study, which right now is asking just the first question, like, if we even started to think about this, like, what would the impacts be? And does community think this is possible? Like, is it worth exploring? Is there a there right now? So it can be like scary because I think it feels maybe like we're jumping, and sometimes you like read the language or like hear the news clips, and it can feel like maybe this is a conversation about the health district getting rid of a program that's vitally important to 1,000 people plus all of their families and community that they're impacting. And that's not the conversation. The health district absolutely, I'm speaking on behalf of the health district as I've been told directly as the facilitator organizing this, and I will give Alicia time to share as well. That the intent here is really like recognizing that these 1,000 slots are vitally important. The health district offers medication-assisted treatment in the form of methadone, which is not a common program. There are only a handful of providers across our region currently that also offer it in the same way. They're only interested in moving forward in a recommendation to separate if there's an organization out there that reasonably could take on this caseload of folks and could do it with the same level of quality, the same level of access, and not create a risk that folks would lose care in the process. I don't know if that's possible. It's not my job to know if that's possible. It's actually Alicia's job right now to be asking and figuring out with you all, like, do we as a community think that's possible? Is that a risk worth exploring? Is there an opportunity there that we should be searching out? So that's what we're doing right now. And I just want to be clear because it can feel like, oh my gosh, are you talking about getting rid of a service that's super important to me and my family? And that's not where we're at. We're not there right now. I want to name that risks are very valid, and that's what we're going to explore. But I just want to be very clear that, like, this is a plan for a plan. Like, we're figuring out right now and wanting to hear from folks. Do you all believe this is possible? And how do you all feel right now about what you know about your health district and how they're currently responding to the opioid crisis? And is that how you want to see your health district continuing to behave, given that the state law doesn't say they definitely have to do it? You know, it's like, I think it's a good time that if it's something you don't necessarily have to do, but it's been going well, it's nice to check in with community and be like, hey, this is good, right? Like, we do want to still keep doing this. So that's kind of where we're at right now. There's my casual run through of this process, and I want to pause and create an opportunity for Alicia, if there's anything that I've said that sparks a, like, anything that you might need to correct, anything I forgot, anything you want to share. I'm opening the floor. And also, you should introduce yourself, because I forgot to do that. I'm so sorry.
So hi, I'm Alicia Thompson. I'm the administrative officer for the Spokane Regional Health District. And I just want to thank each and every one of you for being here and those that are watching streaming, because it is critically important that we get your voice and hear your concerns, because that's how the Board of Health is establishing their decision matrix for how they're going to make their decision. And so your feedback, your comments are extremely important, and I greatly appreciate you taking the time to be here.
Thank you. Okay, so we're going to move into a space where y'all can ask questions. I'm going to switch back to this slide. I want to reiterate that where we're at right now is this is a three-phase plan. So at each phase, Dr. Thompson gets to do this research and gathering information, and then she'll make a recommendation. She'll submit that recommendation to the Board of Health. Right now, we're on track for her submitting that recommendation in August, so that the September. We're going to finish all the data collection in August, so that at the September, it's the fourth Thursday of every month. Last Thursday of every month. Oh, wow, I almost had it. I got 100% of those facts wrong. Is that an almost? Okay, anyways, September, last Thursday of the month is when the Board of Health is going to be presented the recommendation, and we'll be making their vote. So at each phase, Alicia makes a recommendation, and then the Board of Health votes to either approve or reject that recommendation. If Alicia's recommendation from this first phase is, nope, I don't think that there's enough there, we shouldn't explore it, let's just keep the program at the health district, then she presents that to the Board of Health. The Board of Health can vote yes or no. If they agree, the feasibility study ends. We don't move forward in any other phases. If the recommendation is to move forward and the Board of Health says yes, then it goes into phase 2, which is another exploration of like, okay, well, now let's get to the details. Like, how would this even be possible? Are there organizations out there that could do this? What's the criteria that we would use to determine who the right entity should be? And really trying to like figure out the actual details for, is it possible to do this in a way that maintains the integrity of the program? Dr. Thompson then gets to make another recommendation to the Board of Health that they either vote to approve or reject as to whether or not they should move forward to have a request for qualifications, which is when they release a document that says, hey, organizations, who's interested, who might want to take on this program, and they'll source it through that public process. So 3 stages, opportunities for it to go forward or not. Alicia gets to make a recommendation to the Board of Health. The Board of Health has the final say into whether to approve or reject those recommendations. This is my summary of the process so far, and my just enough information to be dangerous and hopefully get you to start thinking. We're going to do a little community process today where I get to hear directly from you all. And not everybody likes speaking up, and I totally understand that. So we're going to do some like slow burn practicing into it. One, I want to just create the opportunity for folks to share if they have questions about this process, like clarity, I don't get it, there's more information I need, I have a question about the program, I have a question for Dr. Thompson, whatever it is, like we'd love to create that time. And then we're going to move into a space where y'all are going to be working on your worksheets. You'll have a chance to talk to folks in the room a little bit and then share back out with us. So I want you to mentally prepare yourself for a little bit of extroverting if you have it in you, because this sort of work is much more valuable when you're sharing with other people and hearing and exposing yourself to perspectives that you may not have otherwise had the opportunity to hear from. So that's why I'm going to force you to do a little bit of this. Thank you for bearing with me. With that, I want to open the floor and see, based off everything I've shared so far, what questions do you have? Like, let's just start with clarity. Is there a space where you need more information about this process? Are there questions about why this is coming up? Anything at all? Totally ready. I didn't warn my mic runners that I needed a mic runner now, but this is the now.
Is there a world where a public health mandate will be put in to consider the opioid treatment to be a part of the commission of the regional health districts across Washington, to get the more state funding that was discussed as not currently being available?
At this point, I haven't heard anything of that nature.
Thank you. This is not on. Can I just talk loud? Or
No.
does it,
Oh,
there's
I forgot. Oh, it's on now.
it's on. I just am scared. Okay. Thank you for this and for this opportunity and for being here. I have a question, kind of a two-parter question. Are there other examples of prioritizing SRHD programs, and does that help us understand what might happen to staff, or like how does it gone in the past, if so? And if not, what will happen to staff?
Right, and that is, so there are a lot of staff concerns. And so that is part of the decision to move forward. and a part of the decision matrix that the board will be following. And so we do have WIC and Nurse Family Partnership, which aren't core services. And so we haven't looked into at all separating those. I know in the past, and I should let you know, I started my position on December 11th, 2023. So, it goes, I do have a soft voice that microphones don't like, so I apologize, it keeps going back and forth. I know that before I was appointed to be the administrative officer, there was a program, the Breast and Cervical Health Program, that was separated from SRHD. But I unfortunately don't have the history or the deep depth understanding of why that happened or how it happened or the decision-making process. I know it did have a fairly negative impact on the community, which is one of the main reasons like I'm here today. Because I felt under my leadership, I felt it was incredibly important that this process be transparent and that that people, our employees, our clients, the community, that everyone would have an opportunity to voice their concerns. So does that answer your question? Okay, thank you.
Was that both parts of your question?
I'll take a break.
Anybody else? Well, Amber takes a break.
Hi, I'm curious if there are current active private companies that are named and being considered.
Yes, because I've talked to them. They wanted to talk to me. So yes.
Would a new entity be created possibly as well?
It absolutely will. So that's a really important question. We're not talking about contracting with another organization. We're actually talking about having another organization take on treatment services. And that's why it's such an incredibly sensitive and a sensitive topic. Did that answer your question? Okay.
Hi. Ooh, wow. Okay, there we go.
Yeah.
Hi, everybody. So I'm loud. I don't have a soft voice, ever. I'm a group private practice business owner, for some context. And I have a question about how, well, I guess I'll just frame it this way. If I understand correctly now, Spokane Regional Health District bills for services.
Yes.
With access to extra funding if they're in the red.
Right. That is one of the benefits of
Right.
being within
So-
government.
Private practice groups do not have that option, ever. And the ability to be reimbursed by insurance is dependent on a million small factors that could mean you're not being reimbursed for services for months. What process will be put into place if you get to the stage where you're looking at, is this really a feasible option? To make sure that if you're going to go from a service system that involves extra funding to protect services to one that does not have that, what's going to be done to ensure that services aren't decreased because in reality, funding has decreased?
Right. And so what you're talking about is step 2. So we would have to do a full fiscal analysis of what would be the criteria of anyone that would be like eligible to even submit an RFQ if we make it all the way through step 3. Because an RFQ won't happen until we made it all the way through. Sorry. Thank you, Ollie, for reminding me not to use acronyms. Request for qualifications. Yeah, that's what that stands for.
Gonna go back here
I want to make sure that I get your your question fully answered before I move on to yours. And so I just want to make sure that everyone knows that the fiscal stability of any organization that would submit an RFQ would be a very high scoring matter. Does that answer it? Okay. Okay.
And I forgot to mention that because we do have folks on Zoom, it's important everyone use the microphone because that plugs right in. So thanks
I'm sorry.
for
Do we
dealing
have
with
a
it.
third microphone or? So sorry.
Hi.
Hi.
Just to let you know, I'm not an expert in this at all. I work at a disability action center.
Okay.
And from my understanding, the health department does treat people who don't have insurance.
Absolutely.
So what would happen to those people?
Again, that is part of the decision matrix.
Okay.
It's like so the data center at the Spokane Regional Health District has really helped me to turn like the concerns into a measurable construct. So like payer mix, that is a huge indicator of whether or not another organization's their way of providing treatment aligns with ours.
Okay.
And so, for example, 80%, a little over 80% of our clients are covered through Medicaid.
Mm-hmm.
And so if we find out that, I mean, if there's an organization that's like 65% Medicaid, it's like, you know, are they really going to be able to offer the services that we offer to our clients? We also have a sliding fee scale, and we have other ways to cover the cost, and we have not discharged a single patient for lack of ability to pay for over 5 years, because we are a safety net provider. And so that again is another factor that is there any other organization with a vision and a mission and core values that aligns with the Spokane Regional Health District's treatment services?
And just to follow up on that is there numbers, like how many people are receiving treatment and how many people are not insured that are receiving treatment or have?
Yes,
Okay.
and I've developed a dashboard,
Okay.
again, with the help of our data center that identifies those type of data metrics.
Stage 3 is all about transition. And I'm wondering, as you bring on another provider, you lose the incentive for staff to be employed. Is that going to be a crucial part? Is how do you maintain care while you run parallel services and funding becomes dubious?
So in my because I have been talking with other opioid treatment programs that are potentially interested if we make it all the way through step 3. And I'm going to give a quote from one of those organizations. And what they said, what they told me, is that expertise in providing opioid treatment care, it doesn't grow on trees, right? It's not, there's not a whole, I mean, there's not people waiting in the wings that could be hired. They said, you know, if it went all the way through, that they would absolutely want every single employee to come with the transfer, because they wouldn't be able to staff it, and so the transfer, it would be seamless. It would be like patients wouldn't even know that there was a change in his experience.
So I saw a bunch of hands pop from that. Can I let these folks respond to that comment before I come back to you?
Go ahead.
I'll go, Susie.
Yeah.
Thanks, Hadley. So I'm Susie Saunders. I know you, Dr. Thompson.
Yes.
I am a Protect 17 union representative that represents the majority of workers at Spokane Regional Health District Treatment Services. And do you know, are any of the potential new providers you're looking at public? Because currently, as public employees, these guys have access to one of the best pension systems in the whole country. They have access to public service loan forgiveness. They get insurance through the Public Employees Benefit Board. They have a union who negotiates good pay and benefits. So, you know, you said it was seamless, and I think it could be. Well, yeah, I know it was a different context, but if there are no public providers on deck that could take over, they would lose all of those things. So, are there any public providers that you're looking at?
As far as I've been able to identify, the only other public provider in Washington State is Tacoma Pierce. And they would not, they serve Tacoma Pierce, that area. And so we're the only other public OTP in Washington State. I don't know of any other county, any other governmental entity that provides opioid treatment services in Washington State. So you are correct. That's also another very important piece of the decision-making process.
Thank you.
You're welcome.
Do you want to add to that?
Okay, is it my turn?
Yeah, it's
Okay,
your turn.
okay. You said that because of the funds that you want to try to privatize it, the opioid, is that the point?
No,
What is
that's
the point?
just one piece. Right now, we need to expand services because of what's going on. We just, you know, we don't have like our hours of operation. In another listening session, it was shared with me that our hours of operation are problematic for
Are
people.
you talking about hiring employees, counselors?
Yes. So
Okay,
being
now,
able to expand
let me say
services.
this. At the end of last year, Biden just appropriated $11 billion to opioid and fentanyl.
Right.
And there should be enough funds there to hire, you know, counselors to work with it, because I kind of agree with what this lady over here was saying, is if it's privatized, what's going to happen to the patients that can't afford it, that can't afford their insurance?
Right.
And it is there, so I can let.
Right. That's the opioid litigation settlement funds and other funds. And so as far as whether or not we are eligible for those funds, that's what's a challenge. And also, are those funds dedicated to currently operating opioid treatment programs? And it would be amazing, and it would be amazing if some of those opioid treatment settlement funds were allocated for the backfill of a sliding fee discount program. We have some, but it's not a whole lot. And so, I've been talking with Spokane County about this is a real need. When we have individuals who can't afford treatment, it is critically important that every single opioid treatment program, and now I'm not just talking about ours, I'm talking about anyone providing this service in our community, that they have a funding source to support people who can't afford it. So, does that kind of answer your question, sir?
No, it doesn't really answer my question. My point is that opioid or fentanyl, okay? Why is it that pharmacists, you know, the doctors are prescribing it to the patients? You know, there should be you're supposed to look for answers and solutions, how to
Right.
stop it rather than just keep feeding and keep feeding
Right.
and feeding. That's not going to solve nothing. It just
Right.
gets worse, 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 and that's probably where is the reason where we are at this point. You know, where it's multiplying every day, you know. And the only people that benefit is if you privatize it are the people that are running that organization, that business, that they get their wages, you know. They pay themselves, you know, just to keep dishing it out, you know. And to keep it in with where it's at right now, under the government and under the state, at least we'll have a say in it. As if it goes to privatize, we ain't gonna have no say in it. We'll have to lose control of it, period.
I hope.
Can I ask a question?
Oh,
Yeah.
there's another mic.
So I have two questions. One is, who specifically initiated the issue of privatization? Was it you? Was it the Board of Health? Who on the Board of Health? So why are we asking this question?
Within the first 2 weeks on the job, the issue came up, and I was presented with that they had been looking at it. They being treatment services, the treatment services director, and the Board of Health. The last time it was formally addressed was by, I believe, Amelia Clark in 2021. And at that time, they were looking at contracting out the services. And that's not possible. You can't contract out your NPI and your DEA registration and everything else that goes into running a program like this.
So the people specifically are the Board of Health and the treatment director.
And the treatment director and the previous AO.
Okay. And then the second question is, what are the legal or formal mechanisms that would ensure that current employees keep their jobs
And that's
with a new provider?
That too, and like I see Susie shaking her head this way. One of the biggest risks in this whole effort is that if we made it all the way through step 3, we could write into the contract all kinds of barriers, and like you have to do this and you have to do this and you have to do this. But what happens when a contract's signed? It now belongs to this other entity. The ability to enforce that contract is, I'm not an attorney, but it's like you really take a huge risk and trusting that the organization that takes it on is actually going to abide by what's written into the contract. But yeah, and I saw hands here and then a hand back there.
I'm going to prioritize folks we haven't heard from, and then there's also a couple that came in on the YouTube.
Yes.
Just to go off of what she asked in regards to the treatment director and the Board of the Health, was there a reasoning, like statement-wise, of why she wanted, or they wanted, to have this feasibility study started? Or was it just, hey, this has been something we've always been curious about, let's just do it and get it over with? Or was there a specific reason?
My understanding of the reason why this comes up every so often through the history of SRHD is, number one, we started because nobody else was providing the service. And typically when others in the community are providing the service, public health steps back and allows the community to provide the services. And so that's one reason. The second reason is the crisis that we are in. And government, who has not heard of government red tape? Everyone's heard of government red tape? It's real and it's there for a reason. It provides parameters and clear expectations of how we are to do business. We have to be transparent. We have to be wise stewards of the taxpayer dollar. Everything we do has to have a process. And I appreciate, I've worked in government or federally qualified health centers my entire career. And I appreciate the way government functions because it's necessary to be transparent and to be able to ensure our community members that we're doing everything right and following the steps. And so we're in the middle of a crisis. We had a shortfall in 2023. We need to expand our services. We are regularly turning people away from being assessed to get into the services at treatment services. And that breaks my heart. But at the same time, we can't expand our hours and our services because we ended last year in a shortfall. And in government, you have to have the money up front to be able to say, we have this money, we want to expand services and use that money. And so that's one of the other reasons is we are in a crisis. Are we doing everything we can under the very much appreciated barriers of governmental process? Does that answer your question?
Yeah, I had another one. A lot of other people brought up individuals who don't have insurance that are receiving services. I know another big population was pregnant women and also individuals who are in jail. I know the health district is the only opiate program that goes and serves individuals who are in the jail. So has that also kind of been question of what would happen as well?
Yes. Yeah, that's a question that I've asked.
We're going to take a moment to let Heather share some of the comments that are coming through virtually. And then we have like 10 more minutes of clarification before I force you into my activity. I'm warning you.
Okay.
Is this mic on? Okay, yes. Okay, question that came in. Dr. Thompson, in your conversation with Range Media previously, you stated that treatment services is not a covered core services by the FPHS.
Foundational Public Health
Foundational
Services.
Public Health Services, yes, sorry.
Yeah.
I was trying to
That's
translate it in my
okay.
head.
That's okay.
Does this mean that the district is only going to have services that are funded by Foundational Public Health Services in the future?
No, and so that is when I was talking about we have WIC. There's actually a document that I believe has been shared, like when we held our town halls, SRHD held our town halls, we shared that document with community members. And so it shows what's core. And then as Hadley mentioned, there's other services that can be provided. And so we're not looking at WIC or Nurse Family Partnership, because if you had that graph, Hadley, is it any way to send the graph out? I know Range Media has it. What?
Heather, did you have more from there?
Yeah, I have more questions.
Okay.
Okay, so another question. You talked about other organizations definitely are going to need staff in order to serve, 1,000 clients that would be transferring over. And of course, the question about union representation and benefits. Is there any kind of guarantee or arrangement that's already been made for the director of services and what their role might be in a future organization?
Absolutely not. No, there's absolutely been no steps like that at all. At all. We're totally in step one. I can't even imagine that would be a conversation until we're in step 3.
Okay. Okay, I just want to say that, okay, now, you're talking about red tape. Okay, red tape is in the government and in businesses. Okay, now, when you talk about moving it to making it private, moving it to privatizing, okay, now, they're going to contract the government and do the same thing. I mean, you know, if how you mean, red tape is where we're at. We can't deny that, and I think that's just kind of the way you answered her question over there is kind of a poor excuse. Excuse my language, you know, because it's everywhere, and when it's privatized, and this is how a lot of things are done. It's private organization, and they're not allowing the people that it's supposed to help. And the government is spending more to the private organizations, and I think this is what's going on. You know, it looks like that way, though. You know, because red tape is here, and we can't deny it. You know, it's because people cheat all the time. You know, unfortunately.
Thank you.
I think that some of the tone of this conversation is like we got to choose the tape that we want a little bit. Oh, we're good over here. Okay.
And we've got two here. You have the mic.
Okay. Wouldn't it be better to just restructure the program to accommodate the needs of the community to address the opioid crisis instead of looking at separation? Because I'm sure there are a lot of staff that would be willing to look at restructuring if that means not having to separate, because we want to accommodate and help the people that are suffering from this.
Right. And so that is potentially going, well, and I'm trying to choose my words wisely, but that is, if truly, I'm just going to be straightforward, if the program stays within treatment services, it does need, it needs a commitment, kind of like the Board of Health committed to equity, right? And part of that commitment came with ensuring that was funded. And so if it stays with SRHD, it's going to really need a resolution from the Board of Health that says they are committed, and because of community support, because of the results of this, if that is the recommendation to stay, then we are going to need to make sure that that commitment is there to keep treatment services as part of the health department, and that it will be supported. Does that answer your question? Okay.
Hi. Right here.
Oh, hi.
Is it a concern or a consideration now that there is currently other programs in town that have sliding scale SED programs, not to this scale for sure, but if we're considering that there's this big market and there's this big need, that we have big, powerful private organizations that aren't meeting this need already, and with that, wouldn't this maybe function better if we had a split of public and private instead of just gutting our public to private?
And those, again, are valid concerns that have been spoken. And so it's been worded differently, but that is a concern that I've been hearing throughout our listening sessions. Yeah.
I see we're maybe entering into the space where some of the clarity questions are turning into opinion questions, and that is good. I like the opinion questions. We are also here to get your opinions on what you think, and I think sometimes, I just want to name that it can feel unsatisfying when you're like, well, isn't this the obvious idea? And it's like, the answer is, yes, we do want to hear that from you, not necessarily yes or no, or a decision has been made, or this is what we're going to do with that information. But like a lot of the answers to what you're saying is, yes, exactly. Keep it coming. So I'm going to check with a couple of hands up to make sure there's still sort of like clarity or like big picture questions. And then I'm going to move us into a little bit of our worksheet. I already see a lot of you filling it out, which is great. There you go.
I was the gentleman that just spoke. I was going to say the same exact thing. But because the word epidemic and crisis is continually used with opioid crisis, I went to another town hall a while ago on the same thing, and
The library will be closing in 1 hour.
But I mean,
if you have items in the storage area, please retrieve them now.
And
the first floor restroom will be closed in 15 minutes. Thank you.
So, and I know that you'd mentioned Tacoma, and I don't know other states' numbers, but everybody's in a crisis, right? And I think it's obviously going to take, the health district and privatized companies to get anywhere, because we have not gone anywhere with it. I think it getting worse, like you mentioned the numbers of deaths. So in Spokane, this is a community that has changed, has grown, and in order for us to continue to be the community that we want it to be, it has to be a partnership. And because like you said, there's not all these places like, oh, we want to do it. we'll help people who are unhoused, or and so to me, someone who doesn't have the information or the numbers, it's very obvious that it needs to be more than just private entities, unless there is a big city that is like, hey, we've privatized and we're doing great.
Any other last general comments? Oh, here we go.
And Susie.
Now I'll go up to Susie.
Hi. How do we make the OTP program a CFS so that it can be funded fully?
What's CFS?
Core foundational support.
Oh, sorry, FPHS. Okay, so that would require change to the legislation. Yeah, the state legislation.
Red tape. Yeah.
And maybe a little advocacy. Hint,
Right.
hint.
Let's do it.
Yeah. So, Susie?
As I understand, there could be a situation where you recommend don't separate, but the Board of Health could disregard your recommendation and choose to go forward with privatization. What would you do if that happened? I know that's a tough one. Sorry.
I want to let everybody know that at our upcoming Board of Health meeting, which is actually tomorrow, you can join it online on our website. You just go Board of Health meeting, and the link should pop up. And the in my AO report to the Board of Health, the policy committee of the Board of Health has been developing a decision matrix, and my AO report is going to go over the decision matrix draft so that all Board of Health members can see the direction we're going with how they're going to make their decision. And so I would encourage everyone that has the same interest to please attend the Board of Health meeting tomorrow. It's at 12:30 because it will be a part of my AO report. Okay?
Thank you.
Okay, so just in listening to this and understanding and want to relate this to everybody else, that ultimately this is going to be our Board of Health decision. I want to go ahead and say that the Board of Health currently is short a representative, and that's the tribal representative, which there is a mandate where they must have this person there, this representative there. And so I just kind of want to remind people of that, and if you can encourage the Board of Health or the powers that be, the commissioners, to go ahead and appoint out of the good pool of people that are available and willing to do this, to get on that, because I think we're kind of counting chickens before our eggs are hatched. And I think that's a piece too that really in my mind has been kind of missing, only because tribal people, and we have tribal governments, sovereign nations that are kind of around Spokane, and I don't know, perhaps I I'm not legalese. I'm, don't know about these things exactly, but because there is this same epidemic that seems to be compounded on reservations and we're surrounded by them, could there possibly be an opportunity for tribes to step in and to be able to facilitate something like this for the greater region? The other thing too is I'm just going to add my 2 cents. I have found, being an addict in recovery, I have had an opportunity to participate in SRHD's opioid treatment program in the past, and other treatment programs for opiate addiction here in Spokane. And I've run the gamut from, it being tough to access services and the medication, to really feeling like I was an absolute number and it didn't matter how sick I was, what I needed, as long as they were able to meet their 15 minutes with me and bill for services, that that was okay with them. And so for me, when I hear privatization, one that kind of sets up this mindset that I'm going to move into, I'm going to have to try to access services about, from somebody who doesn't care about me, as an addict, in active addiction, we carry like a huge weight of stigma as it is. And so being able to kind of go to these places, would be yet another barrier to treating, to getting some well-being. And, and then on the other side of that, now that I'm a provider in the community, like really seeing these privatized treatment programs really kind of run a racket, and taking advantage of people or not treating them at all. And so in my mind, I feel like, that there should be a possibility, and we really should be like more forward thinking about what we can do. OTP at SRHD for the last 30 years has been stood up out of a need, and now that we find ourselves, even us as providers in the community, with this fentanyl, like it's even changed from the fentanyl that we saw 5 years ago. And so I'm thinking of like not just methadone, but the other 2 medications for medically assisted treatment, could be highly utilized. And really we need to kind of like join together with all of the other intersections too, of why people are using and why that's a solution, and the things that we can do to kind of take care of the whole person. And I'm just going to go back again, that is really, being a Native American, that is a core value that we have, is that you have to treat the whole person. And if you meet their needs, then the issues kind of fall away. And so I would hope that that would be in consideration, considering that we're here in Spokane on the unceded lands of the Spokane people. And, this has always been a gathering place, and we always took care of each other. And I think that piece with the tribal representative is really important. And to kind of just, remember that community has this voice, and we need to acknowledge that.
Thank you, Angel.
All right. I am once, can I just thank you, Dr. Thompson, for being in the hot seat right there. Thanks all for your questions. I hope that gave you a moment where maybe you've heard something new or thought about things slightly differently, and that's the perfect timing for us to break into this activity. So we're going to just, for the next little bit of our time, have 2 conversations. We're going to break them into 2 separate conversations. That's hard to do sometimes, so try the best you can to put in a box. The very first conversation we're going to have is just about the health districts program right now. Like, as it stands, what are the good things about it? Like, what are the strengths? What are the things we're hearing that we really like about it being based in a public program? What are the things that we're worried about? What are some of the weaknesses? What are the limitations you've heard? I'm going to give you all about 5 minutes which is a chance for you to mingle, to move, to stand up, to ruminate if you need. But the thing that's exciting to me right now is you all just got to hear from each other. Some maybe new thoughts, interesting perspectives or idea. This is a great chance for you to actually stand up and maybe go ask someone a question and be like, hey, I heard you say that thing about this thing that you're worried about could happen at the health district. Can you tell me a little bit more about that so that I can try to understand my thoughts and comments more? Like, this is a chance for you all to lean on each other. So the first question, we're just doing one at a time. I get clarity, and then I'll go. I see some hands. We're only talking about the health district program right now as it stands first. So like just where it is today, if it stays, what's good about it, where are there opportunities to maybe make it better. Then, after you guys get a chance to mingle, we'll all come back. Y'all are going to share. Tell me what maybe came up, what themes you got. And then we're going to repeat that process, but we're going to do it for the question of what would be the opportunities if it privatized, and then maybe what are the risks and the threats. Like, what are you all afraid of? We've heard a lot of things if it does go private. So 2 separate conversations. The benefit of breaking them down is that we just can really like kind of focus on what we're talking about. I am asking folks to try to maybe talk to someone new today if you have it in you. I'm going to check to see if there's questions about this process, and then I'll give us mingle time. Alicia, I saw your hand.
I would prefer not to be part of the. Yeah, thank you.
Yes. You can have a break and eat your snack over here. If there are questions for Alicia during this process, I would love if you maybe direct them to me so that we can make sure we put them back on the full public conversation, just so we're being really transparent. So if like in this time you have questions, we can ask them during the report out too. Any other questions about what we're about to do? Okay. The time is about 10 after. So at about 15-ish after, I'm going to ask you to come at. And oh, one more question. Yes. Oh. Gotcha. Sorry, I got confused. I'm back. I'm with it. I'm focused again. Anyways, 5 minutes. Mingle, think, talk. You've already written so much. If you need to get another piece of paper to write your things in, there's more in the back for sure. So go ahead. I'm going to give a gentle 2-minute warning to be wrapping up your conversations and thinking about sharing. Okay, all. Do people feel like they're at a place where they could share out a little bit? Or do they need more time? Put your hand up if you want another minute. Move to your seats if you don't. I've been lovingly prompted by our videographer that I pace a lot, and it's a challenge for the folks who might be trying to watch along, so I'm going to try to do a better job of being here. But with that, so I floated, I heard some nice things, and I saw some people meeting and introducing themselves. So thank you. That already feels like a win for me. But I want to start with just focusing on this question, only this question right now. Number 2. What are the current strengths and weaknesses of the opioid treatment program at SRHD right now, as it stands? How are you feeling about it being at the public health program? This is the chance for opinions instead of questions.
The two things that struck me is in the last 5 years, they've not discharged a patient for failure to pay, as well as they're the only service provider for the jail. So they're meeting people who may not be able to get treatment elsewhere, which is incredible.
Is this for this section?
Hi, I'm a recovery navigator, and I work at
Get it right up in your face.
a lot of shelters. I do referrals to get people in, like on a daily basis, to get into detox. One huge barrier that I see, because I think most of all know that when somebody is contemplating change or wanting help, there's a short period of time that we have to act. And the problem that we have a lot as providers is we only have 1 or 2 places where we can get them signed up for methadone treatment. Well, a lot of stories I hear every day of, I'll have people, say 5 people that will be at online before they open. They'll wait there for hours, and at the end of the day, when they open, they'll only take 2 or 3 of those people that have been waiting hours so that they can have their prescription for when they go into treatment. And the rest will be turned away, and it's a problem. because sometimes we don't see those people that wanted treatment because they get discouraged. And then when we tell them you have to go and get prescriptions to take with you into treatment, a lot of times we won't see them again until months later. And as you all know, some people don't make it. They either don't come back or we lose them. And it's happening every day. It's a huge problem. And I'm just voicing that as a provider in hopes that could resonate with you all, So that's it, my opinion.
Thank you. Do you want to say anything too?
And I'm a dad duty.
Say good job, Dad. Say good job, Dad. We're trying. Back there.
So I'm actually one of the counselors that works in the program. And we have a lot of patients that come from private run clinics, and I notice they tend to stay in our program a lot longer because they know we're compassionate and we listen. We treat them like they're a person with a name versus a number. And even if a private clinic is closer in proximity to where they live, which nowadays, as we know, with inflation and things being expensive, gas, a lot of our patients are low income, can't afford gas. They would rather stay in our program than go to a private clinic where it's closer and would be essentially cheaper for them because they know they receive good-hearted services with us here at SRHD. And so right now we utilize special mobility services for bus passes and gas vouchers. So we also work with them to be able to communicate their carry schedule so they can get bus passes for them, as well as gas vouchers if they have the required necessary documentation, because we want them to come to the clinic. We also are, with some changes in the program, more able to give them extra carry so that way they can come to the program because we want them to be successful.
I'm largely saying what I said before, but now from an opinion standpoint. OTP at the Spokane Regional Health District can do something my clinic can never do. And I will get really emotional about this. They can see people who can't afford their deductibles and copays. I have to turn them away. That will never change. You're not going to find a contract with a private organization that can do that.
We three are counselors that work there. I'm another one. And I was going to say the same thing, that a lot of patients who come from private practices end up getting really emotional in my office because I'm actually taking more than 15 minutes to listen to what they're going through in life and what resources they need. And let's get you housing. We provide as much, and we're so engaged, at least we try to be more engaged with what resources are in the community. And hey, I know this one, this other counselor knows this one, we're gonna get you the help that you need. And we often call them every day. Hey, you're not here, where are you? And they like that accountability, and we're right in the office where they know that Isabella might be busy with somebody else, but I know she's going to take the time to see me. And we offer Suboxone now too, so that's another MAT service that we're even opening the doors for more people to get involved with. And our mental health. We also have mental health services at the health district, and usually a lot of other people have to go to Frontier, who's super busy. I mean, we're all struggling to find mental health at this point, but just for them to know, hey, you have a referral and somebody will be calling you in a day or two. She's on top of it and making sure that these people's needs are being met. And so I know that there are some barriers at times, but staying public is going to be so important for this vulnerable community to know that there's people that actually care about them and want them to be successful in life. So.
It's cool that you three are here. It sounds like you are a strength of the program, so thank you. I think Dr. Thompson, you also mentioned a strength of the program being within the health district, and that's the data center, and your ability to monitor and evaluate and communicate data from the program. I think that's going to be a huge loss if it goes private.
I'm going to see if there's just one or two burning desires for us. Oh, thank you. Right here.
I think one of the huge things again is that you guys take anyone there. Just speaking for myself, when I got on Suboxone, I didn't get my Suboxone right away, and I was in withdrawals, and that I got fortunate because I was in the sobering center and they gave us grace and let me leave with him for an hour and have his Suboxone and come back, and they said, we'll hold your bed for you. But had it not been for that, I don't know if I'd be sober today. And so, sorry. But, you know, I mean, just the ability to have it open for anyone to come to, because it makes it huge for anyone. And so just knowing that that's there for everyone is huge. That's all. Thanks.
Check out materials.
Thank you. Yes. Deep appreciations for your sharing. We're gonna let that happen. All right, I'm gonna go one more over here, and then we're gonna do our rapid, like 10 minutes on the flip side, like y'all getting a chance to talk about what our fears are or what our opportunities are for privatization. So last comment, and then we're doing another breakout.
You know, and I guess I'm not trying to shed bad light on it. I just would really hope that maybe like make a couple of times a day where people can go, and that's one of the main reasons is maybe you guys can consider maybe one at 5 a.m. and one at, say, 2 p.m., you know, give more people opportunities. But one of the things that I heard a lot was why they were being turned away, because they were short-staffed. I guess that raises another question, like, why are they short-staffed? You know, and yeah, you guys are doing great. You guys are great counselors over there, but we just need more. We need more times, more programs, you know.
Thank you. Definitely speaking to how big the need is. Okay, we're going to do a flip now. Same thing you just did. You heard the announcement, so the library is closing, so we are on a time crunch here. I'm going to give you all 5 minutes to stand up, talk with your peers again, but this time I want you all to talk about the possibility of privatization, opportunities, risks, threats, what scares you, what excites you. I want to give a quick little announcement really quick. Dr. Thompson called to my attention an opportunity for a quick correction. Do you want to make that? I'm going to make it really quick. We were talking earlier about is there any public entity that would potentially take this on? And it's worth noting a caveat that one entity that's spoken up as being potentially interested is Camas Health, which is a tribal run program of the Kalispel tribe. This isn't public in the sense that of like a public health program, but it is a sovereign nation, which is treated like a government to government relationship. So I want to caveat that there's like a public asterisk when it comes to the possibility of working direct or of transferring this program directly to a tribe. So quick correction was noted. With that, stand up and mingle again, y'all, and ask about how it feels to potentially separate. And then we'll do a rapid once again, 5 minutes of share out, and then I'll send you all home with cookies. Until 1 minute. So, wow, that was shocking. I apologize. And then my cackle made it work. Gentle 1 minute, y'all. Loving gentle 1 to 2 minutes. Okay. I hate that time exists. It's an illusion that we don't always have to pay attention to unless we're hungry and need to go home. Here's my gentle rambling to call folks back. Raise your hand if you need 1 more minute. Okay, I see it. Thank you. 1 more minute granted. Okay, folks. Can I lovingly call you back? I got an approval. I got a yes. It's okay. I wish I could leave y'all to keep talking about it. And the cool thing is that, right after this library closes, y'all can go wherever you want and keep talking about it. And you can invite me if you want, and I would love to join. But I'm going to respect our wonderful library partners who are granting us this space and make sure that we get them all out on time. In 5 minutes, you're going to hear an annoying announcement that warns everybody that this library is closing. So, what do we want to share in 5 minutes, y'all? What feels really important that you want folks to know?
Okay. So, I think the only things that I can think of about that would be good immediately in my mind about privatizing is the ability to be more nimble and to be able to be spread out further into the community, maybe in satellite, because most of these private places either are in places that are easily accessible or they have different, satellite offices. But I think, that could be something that SRHD could do along with community. Like I know for Yo-Yo at Spokane, we've been able to provide services or connect with people like at Compassionate Addiction Treatment. I have a little space there that I could use. American Indian Community Center, Native Project. I meet at the libraries. I meet in other public spaces. And so that's something too that I would think could be really accessible. And I think about too, like the advancements in being able to engage people who want to access these kind of services. I've seen virtual visits with providers where people can get, meet with a nurse or a medical assistant and either talk to virtually a nurse or a doctor and either get a first dose of medication at that visit and or get a prescription for their medications as well in that first visit. At my time at the Bail Project, we worked with an organization here in Spokane, and I was even witness to somebody that was released from Geiger, and we took them to Airway Heights, and they got their first dose of Vivitrol in the Maverick bathroom. So I mean, it sounds kind of seedy, but I mean, this person did really well to kind of move beyond that. And so the other things, I think that are so immediately those are the things that I'm thinking about, and beyond that, I think if there was the ability to expand and be in different spaces and places that are community based, like that would serve the folks who have been inhibited to access services through SRHD, because I know some of the folks that I'll refer to them as, being their voice in this space right now, that often they go to these places and they don't see people that look like them or talk like them, and even with the providers. And so I think there's an opportunity to put that, that cultural sensitivity piece to be able to have a better reach for people who really need this. And then the other thing that actually just really scares me is in privatization, the funding piece. I love that SRHD doesn't turn anybody away. And I just want to, the other thing too is, just this, there's a culture of turning addiction services into rackets. And, who pays for that ultimately are the people who die from their addiction. And so kind of keeping that in mind, SRHD, they're regulated, it's transparent, we know who's there, we know who's going, we know where they're coming from, we have all this data collected. Privatization, I think, that could very well fall to the wayside.
Hi, Erin from Range. I've been fielding online questions and comments. This one says, I would be against privatizing any healthcare services, especially to a for-profit company. Why would this be a good option if there's no accountability? There are already for-profit healthcare companies who are overcharging patients and Medicare and Medicaid. For-profit insurance is denying payment for care and overbilling as well. For-profit healthcare makes care more expensive for everyone, so privatizing opioid treatment could end up hurting people who are already vulnerable.
Thanks for bringing that in, Erin. I'm going to go one more, and we get one more after you.
Yeah, PwC issued something that says 8% year-on-year increase in privatized healthcare costs to the American populace. So that is a terrifying stat. Another one is that the pro is that by some crazy bureaucracy, there's funding available for private institutions and not the one that's providing great care that we've heard from these wonderful people who work at the clinic. The other one is there's a transition, and the thing that scares me is that transitions, as somebody who's been through 3 in the last 5 years in a private to private, regardless, there's a month of benefits changing, there's a month of workplace harassment training, and unfortunately, that's people's lives in this care. So that's one of the big threats is people will die if we change.
Thank you for naming that so clearly. Oh, look at that.
The library will be closing in 15 minutes. Please gather your belongings, check out any materials now, or see a staff person if you need.
I'm going to give Ollie the last word, unless there's a burning desire, and I'm wrapping up very rapidly.
Thank you for everyone attending today. I work in the health equity department at the health district, and this is something that I have a lot of passion about and feel really dedicated to our community to make sure that we are supporting them and caring for our community members to the best of our abilities. And one of the things that I wanted to name as something that I'm concerned about, especially since we care for and provide treatment to those who are in jail, that the process of someone going through withdrawal while in jail and then coming back out of jail, their rate of overdose is up to 100 times more likely. And that isn't an exacerbation. That isn't me making up a number. If anything, it's probably lower or probably higher, the rate of overdosing coming out of jail. And so that's something that I want to name very directly. Is that something that our services help provide and cover that very dangerous gap for our community members who experience that. So that's something I want to name as a concern. Thank you.
Thank you all. I would love to keep going, of course, and the conversation can keep going simply by you answering our survey, where you can share even more if you have more thoughts. I am going to ask to collect what you've written down where possible, where you feel comfortable. Feel free to just leave it on your chairs or throw it on that table as you exit. We're going to do 2 more sessions that are going to be Zoom only. Town halls. So if there's people that you really want to make sure get in this conversation, let them know. We have some flyers on the table that you can take with you and share. And also you can just follow up with me. Feel free to reach out and we can set up a time to continue talking or find more ways to get you plugged in. My goal is to have this information all wrapped up by August 15th. So over the next week, I'm doing like massive amounts of outreach to all sorts of different folks. So feel free to reach out. I heard so much care for this community expressed in the comments that you all shared. And that was really beautiful and grounding. And I hope that you all stay tapped in as we continue to support the health district in figuring out this process and listening to you all in the feasibility study. So with that, if you signed up your email, you'll get updates from me on this process. You'll get the copy of the report that we create and everything like that. I'm going to blessingly ask you all to speedily leave without, any harm while going down the stairs. And with that, thank you so much. Have a wonderful, blessed, happy, joyful evening. That's what I got.